Yes, welcome everybody. Good afternoon. I'd like to, on behalf of the Program Committee of SACME and the Editorial Board of the Journal Club, welcome all of you to this very exciting session today that is going to feature flipped classroom concept in medical education. And before we turn it over to Barbara, who will introduce our primary presenters today, I'd like to take just a couple of minutes to remind you of the Journal Club and all of its features and what it really has to offer. So this is a relatively new member benefit for our SACME membership, society membership, and as many of you who are joining us may know, this is a free of charge benefit to SACME members. I'm also very excited and happy to welcome those folks who are not members of SACME yet and who have chosen to join this session because this is the first time we have actually opened it outside of our membership. Just so you are reminded, we have live sessions. We also have a calendar posted on SACME website where you will see additional sessions posted, as well as discussion forum that happens asynchronously. And we do have archived sessions. So if you have missed one of the sessions, or you'd like to take advantage of looking at the slides or listening again to the podcast, you will be provided with a link if you're not a member, and certainly can access it as a member on the primary website. So really quickly, February 4th and March 6th are our two sessions that are coming up and that I'm really excited about, because we will revisit the concept of effectiveness of continuing education and continuing medical education from two very different points of view. So in February, I'm really thrilled to announce that we have Dr. Robert Englander, the Senior Director for Competency-Based Learning and Assessment of the Association of American Medical Colleges, joining us to lead the discussion around what really determines how we do in clinical practice. And so this obviously has implications. This famous study that provides evidence from David Ash and colleagues on what determines how we practice and how much we can do with continuing education in light of that. Followed by Dr. Dawn Moore in March, who will take the latest Cervera's updated synthesis of systematic reviews on effectiveness of CME, so to take a different lens and look at probably the same topic. So I do invite you to come and join us for those exciting sessions and the ones that will follow. Very quickly, there will be an evaluation following this presentation, so I invite you to let us know how we're doing, what other sessions and topics you'd like to hear about, and maybe volunteer to present one of those. Reminders that if you are to use your audio access to a full degree, please remember to do hash and the audio pin and then hash again. This will enable your really audio access. With that, I thank you very much for attending and turn it over to Barbara. Thank you.
Thanks so much, Mila. Again, this is Barbara Barnes from the University of Pittsburgh. I'm a member of the Virtual Journal Club editorial board, and we're very happy to have all of you here. Just in terms of logistics, Dr. Rayburn and his colleague Dr. Smith are going to give us a brief presentation to really set the stage for the general state of the art of the flipped classroom and some of the experiences at the University of New Mexico. But we really want to make this conference interactive, and if you look at the dashboard associated with the GoToWebinar, you will see that a list of names and the ability to raise your hand if you have a question. So after the formal presentation, we really want to encourage you to ask questions and share your experience. We do have all of you muted during the presentation just so that we won't get a lot of background noise, but if you raise your hand, then I can unmute you in sequence. There's also a chat function, so we don't have too many introverts among our group, but if you are an introvert or would prefer to ask a question through that format, please do so, and then I can raise it to the rest of the group. So without further ado, I would like to introduce Dr. Rayburn, who is one of our active members of SACME. In addition to being a physician, he also has his MBA and is the Chairman Emeritus of Obstetrics and Gynecology at the University of New Mexico, as well as being their Associate Dean for Continuing Medical Education. He's a nationally recognized maternal fetal medicine specialist and also is clinically active, particularly dealing with patients with complicated pregnancies. He's won a number of teaching awards, has had a very distinguished career in funded research, and published over 600 peer-reviewed journal articles and abstracts at national meetings. So without further ado, I would like to welcome Dr. Rayburn.
Well, thank you very much, Barbara and Mila, for inviting me to be with you today to lead in a discussion about flipping the classroom approach in medical education. There are 14 slides. Each of them is numbered at the bottom right. These slides are available if you'd like to have them. The front of our office is depicted on these two photographs. Here at New Mexico, we're celebrating our 50-year anniversary as a medical school. And I'm really proud to say that the original school and the original classroom is currently where our continuing medical education and professional development offices, which I think is very appropriate. I had the pleasure of working for the last year and a half with Dr. Gary Smith. Dr. Smith is the director of the Office of Medical Educators Development here within the medical school. He's been a long-standing professor within the Earth and Planetary Science Department and truly is an outstanding and innovative teaching leader. So I really welcome the opportunity to be here with Gary. I went to him a while ago after he had given a lecture about flipped classrooms, and I was very intrigued with the concept, and I wanted to share that with you over the next 20 minutes or so. The learning objectives are going to be to describe the format for flipping a classroom, understand an ongoing project that we're doing here to illustrate tips about flipping a lecture, and then lastly, to open things up with a discussion about implications of this approach with continuing medical education, and continuing professional development. On slide 4, I think all of you know about the standard learning activity sequence, which involves pre-class, in-class, and post-class activities. Traditionally, we're used to there may be being some assignment, but people not beginning to actually learn maybe until they're in the classroom, usually through some sort of a passive lecture with questions and answers being after the lecture if there's enough time. There then is a homework assignment with some sort of written evaluation. Whereas with the flipped classroom, there is flipped here the activities from the in-class, post-class for the traditional lecture, in which there's offloaded content evaluations in the pre-class efforts, with the classroom being dedicated to interactive learning with subsequent written evaluations. I went to Dr. Smith several months ago, telling him that with our medical students, I've been giving the same lecture every 2 months or so to a new clerkship of students on the same subject. And while the material in my lecture has been overall rated well, I just didn't think I was spending the time in front of my learners really to the best effect. And that's where Gary introduced me to the concept of the flipping classroom. and why I jumped at the opportunity at the fall SACME meeting, looking at the list of topics for a journal club, to maybe talk about flipping the classroom approach in medical education. I also asked Gary, if I were to flip a session, how would I be able to do it? And in reviewing the literature, I came to him with very few articles, and he found probably the best one for us to discuss today was the one which came from the Department of Clinical Sciences at Ross University School of Veterinary Medicine, which had to do with the title 12 Tips for Flipping the Classroom. Now, hopefully you've been able to obtain this at your university library. This came out early online toward the end of this past year, so there may have been some difficulty, but it was my hope that you were able to read this beforehand. Now, over the next slides, from slides 6 through 13, I'm going to have at the top of the slide one of the tips that was offered as part of this article. And what I want to illustrate here is an actual research project that I'm doing to question whether or not there's additional value with flipping the classroom as compared with a traditional class. Now, in preparing my students, what I do is I send out the week beforehand this email in which I inform them that the session about prolonged pregnancy is not going to be a traditional lecture, but we're going to actually try to reinvigorate teaching and learning through this flipped classroom setting. And so what I asked them to do beforehand in the pre-class activities is, first of all, go to YouTube and to look at this 1-minute film from the University of Texas, which has to do with what is a flipped classroom. And it's a 60-second blurb that gives you kind of an overview. And then what I do is I also include a 2-page handout before the class, which is shown on page 7, because it's very important, regardless of whether you're preparing a traditional lecture or especially a flipped classroom, to decide how you want to organize your course material. Investing in your choice of pre-class activities is paramount here. And so my 2-page handout, which can be reviewed over about 15 or 20 minutes, provides learning objectives and a description on the left side there of interactive sessions. I don't expect you to be able to read this. And then the page on the right is an overview as to what I feel is the most important material for the student to understand before they enter into the classroom. So this is the expectation. With regard to the actual classroom, it's important as one of the tips to utilize the flipped classroom to tailor education to the learner's needs. And in doing so, what I first do in the classroom setting is provide what I call a micro lecture of about 3 minutes, providing an overview about prolonged pregnancy. Then I divide our 18 or so students into groups of 2, where one is on the obstetrics rotation, the other is on the gynecology rotation, and I call this pair and share, where they divide up the 18 students or so, or let's say 16, into groups of 2, so that there would be about 8 groups. Then what happens is I go, have them go to working stations. I'll show you a photograph in just a minute, where there are a number of case scenarios. There are certain materials that they can look at or touch and feel in order to answer 2 or 3 questions that I have at each station. Now, at each station, they're there for about 4 minutes, then they rotate, such that over a 32-minute period, there are 8 stations that they go to. following that first half of my 80-minute session, the second half, which is 40 minutes, has to do with the students actually presenting and discussing what they learned at each of the stations. Now, when they're initially reviewing the material, let's go to the next slide here, at each of the 8 stations, I asked the student who's on the obstetric rotation to really kind of lead in the discussion and that they themselves teach, because the other student in the pair who's on gynecology is expected to try to answer the questions before each of his or her group students. So this is how we use the time creatively and effectively, by carefully using quizzes, case scenarios, to really create what I think is a teaching environment where the students feel very, very engaged and very involved. This, by the way, is on Friday afternoons, after lunch or mid-afternoon, when they're, I think, really pretty tired of lectures anyway. I also want to maximize my time with the students by capitalizing on the positive features of the flipped classroom. At our last classroom session, I invited Dr. Smith to be there because I was very interested in his vast experience in education to provide feedback to me as to whether or not this was going the right way. But it seemed to me that to provide an optimal learning opportunity was not to have the traditional lecture, but to have a lot of engagement and interaction between the students, which was team-based, experiential, and problem solving. Now afterwards, it's imperative that there be some effort to try to evaluate the flipped classroom. Was it really that helpful? And one way of doing that immediately in terms of a measurable endpoint is the students actually evaluating or grading how effective I was as a teacher, and to provide information as to the strengths of the session and suggestions for improvement. So I'm gathering this data now. I'm already done with my first half year of doing this, and I will compare that historically to the same lecture material, the same time, the same lecturer, to compare the grading and evaluation of my effectiveness as a teacher. But on the right side, another means of monitoring or evaluating the effectiveness of this approach was having the students compare how this format approach compared with the other 30 or so lectures that they had received on their clerkship that were more the traditional lectures. I was very interested in the attitudes students had toward the experience and their assessment of how effective this was in their learning about 3 or 4 weeks after I had given the lecture. One last point before concluding is to discuss the tip point that had to do with being aware of timelines involved with converting to a flipped classroom. I think it's a real major concern. It requires a fair amount of effort, particularly before the class. It, for me, required learning and incorporating certain technologies. It was imperative that there be an effort to try to devise effective ways of presenting material. But after having done this with a few of the sessions, once it was finally functioning effectively with repeated classes, I found that the overall effort to prepare the lecture was really no greater than before. And I had fewer students coming back to me asking me questions. And when they did, it was more questions that related to the retention of the information and its value. I did mention to the right here, post-class, the written evaluations I thought was very important, which focused particularly on their attitude toward the experience and also their assessment of this approach as to its value with regard to learning a few weeks later. I have yet to look at the data here and evaluate it because I feel it's only necessary that you not interrupt that process for a year or so, but if you'd like, I'd be happy to consider this as a work in progress, maybe poster for our spring SACME meeting. Before turning things over back to Dr. Barnes with regard to questions and discussions, I did want to list on this slide other suggested readings for you to consider. These were all within this past year. The one by McLaughlin may be the one that's known the most. It's from the University of North Carolina within their College of Pharmacy. It involves a much larger class, but it deals with a course redesign to foster learning and engagement using the flipped classroom. The second one is from Hong Kong, which involved medical students who were on a radiology rotation, and it involved a short review of the flipped classroom approach, particularly in interpreting X-ray studies. And then last but not least, from a nurse anesthesia education journal, there was a overview from Duke University, which is similar to the one I just presented to you by Dr. Moffitt, which has to do with the flipped classroom, now or never. So these might be other suggested readings for you to consider. There's really not a lot of literature, and therefore there's not a lot of evidence-based information. But I thought that if you're interested in the subject, it might be wise for you to review those articles. So I promised Dr. Barnes that I was going to take no more than 20 minutes providing an overview to each of you with regard to what I consider to be flipping the classroom approach in medical education. If I may, Barbara, before we entertain more questions, I have Dr. Smith behind me, who has witnessed this actual experience that we're undertaking here at New Mexico with our medical students. And I'd appreciate it if he could have just a few minutes providing his perspective.
Absolutely.
Good afternoon, everyone. The idea of the flipped classroom has been very active outside of health science education for quite a while, and has actually been pretty paramount to the implementation of active learning in general. Most practitioners of active learning, in order to have the faculty and the students engaged actively in class time, realize that first contact with content must come before class. The concept of the flipped classroom has been around a long time before someone made it into a trendy word. And unfortunately, there's also been a lot of focus recently with flipped classrooms and the idea that you tape your lecture and put it online and then have students do homework in class. And that really is not the best pedagogical practice either. Moving the sage on stage to the sage on screen isn't really necessarily providing the appropriate pre-class learning. We're seeing an increased interest among our faculty teaching particularly in the basic science curriculum here as a part of an ongoing curriculum revision to bring a flipped approach into many of our organ system blocks. And it's been really neat to see Dr. Rayburn's effort to show how this could work in the clerkships as well. And I think with these exemplars being initiated here, that we'll see successful implementation of more active learning in our classroom settings in place of traditional didactic with appropriate pre-class investment in thinking about the subject matter before coming.
Great. Thank you so much. This is Barbara. I would like to start the questions, and I'm going to pose this first to the two of you at the University of New Mexico, and then would like to invite comments and thoughts from the rest of the audience. In my somewhat limited knowledge of the flipped classroom, it seems that it's really been deployed in a traditional curricular setting with matriculated students, undergraduate, professional students, et cetera. And I wonder about your thoughts in terms of both the opportunities and challenges for using this model in some of our more traditional continuing professional development venues.
I think we've got a challenge here, Barbara, because I think the flipped classroom is really great if the lecturer is giving the same talk over and over again. They can really use the flipped classroom to kind of reinvigorate their teaching and be more engaged with the students. Our problem in continuing medical education is it's very hard to get people, I would think, to prepare beforehand. And in doing so, you lose that possibility of gaining knowledge beforehand. Secondly, I think we have a wide variety of offerings in continuing professional development, continuing education. And so we may want to target those particular offerings where there might be the greatest bang for the buck. Maybe tumor boards, regularly scheduled series like morbidity and mortality conferences might be more conducive rather than a large, let's say, annual review type of course in primary care. So I think we need to look real critically at our different offerings and try to figure out which might be the best, particularly if it were repetitive and with a group of learners who you would have a reasonable idea would be able to read beforehand. By the way, my reading material is very limited. I purposely intended it to be very targeted, only a couple pages, lasting only about, as I say, 15 or 20 minutes. Within this article, there was a lot of discussion, and there's a wonderful figure about technology available to support the flipped classroom. I think each of us has variable skills in terms of all the technology that's available here. And I think if you're technically adept, then the flipped classroom has greater opportunity for you.
Great.
Just add one other thought, that I think the first thing is, as Dr. Rayburn mentioned, is you need to sort of think about it in terms of the objectives of the individual continuing education offering. And but the thing that perhaps to most keep in mind is that both in the classroom setting with matriculating students as well as some of the studies, meta-studies of the impact of CME on physician performance and change in practice have shown that didactics are the least effective ways of generating learning. So that when you have continuing education offerings that can take away the passive sit and listen mode, which doesn't generally tend to produce very much learning because there isn't much engagement of working memory in the learning process, that if that can be replaced with something that more actively engages the continuing education learner, that's going to be a real plus in the outcome of the program. Then you can ask yourself, is it really going to be necessary for that active engagement session to be preceded by some sort of assignment? And if so, then that's where the flipping really comes in explicitly. But that could be potentially not very demanding of participants' time, where it's a short learning, a short reading rather. Maybe it's a 5-minute podcast. Maybe it's a 10-minute YouTube. Something that folks would probably have a chance to engage with that starts to stimulate the brain to be thinking about the subject, posing some questions that then become the subject of the engagement during the activity, during the scheduled face-to-face time, is essentially the way I would see the potential of bringing flipping into the continuing education realm.
Great, thank you so much. Dr. Stewart Dillman, I think you have a question? Or perhaps he signed off. I think David Piper has a question. David, you're unmuted.
Okay. It was really interesting concept, and I like the idea. Does anybody have any of the audience or the speakers or anybody has anybody done it for any CME programs or CE, CPD, whatever?
Anyone who is on the line who may have done it, can you just indicate to me either by the question symbol or raising your hand?
So while they're just waiting, so I guess I'm trying to visualize how we could do it, and I guess we could do it within RSS maybe with the actual contact time, but it would also, it seems like it would also be possibly feasible to give credit for the prep time that which is kind of the inherent in the flipped classroom concept. And I don't know if anybody has any thoughts on that.
Okay. Stewart Dillman, are you back on?
I may be. Is my microphone working?
It is working. Thank you.
Awesome. Oh, okay. Thanks. I didn't have any example to provide back to David, unfortunately. So I was going to try to change the subject to a different question. It seems like, although there's this emphasis that what's being flipped is simply the technology, going to the lecture being asynchronous and then doing the social learning together during the classroom time. It also seems to me like there's a fundamental shift in the learning objectives with this, that you're able to now really use the time to better develop learner application of material rather than simply knowledge. And I wonder if that's got even more profound implications for teachers or instructors than the simple technology change.
Any thoughts, Bill?
This is Gary. Bill asked me to chime in on that. I think often we really want to see that our learners are able to take knowledge and apply it. And when you're actually able to have that application piece taking place in the face-to-face environment, where those procedures, those conversations about diagnosis, whatever they might be, are being implemented with peers and in the presence of the expert, then you're actually getting a chance to see where the learning that's necessary is taking place, rather than giving a lecture and sending people off and hoping they're able to implement what you wanted. And in the case that Bill showed for his OBGYN students, is those activities that they were doing were very authentic. I mean, they were manipulating pelvic models. They were looking at the tools that were used during these problematic deliveries. They were looking at lab results and being asked to answer questions about them. So it wasn't just about hearing about how to deal with these past-term pregnancies, but they were dealing with authentic problems and questions and issues. And it seems to me that's what we want to be striving for in our CME sessions as well.
I'm trying to combine my response with David and Stewart's questions, and I feel that the future of professional development is really going to be directed toward a team-based effort in improving quality and performance outcomes. And that's where our flipped classroom may be helpful by way of another continuing education opportunity, and that's through actually working on projects where physicians and other practitioners are being given educational credit for identifying problems, reading about that beforehand, and meeting and trying to put together evidence-based protocols that they can apply in their given setting, whether it be in the operating room or the clinic or elsewhere in the hospital. And I think in doing that, David, we can give credit, hopefully, for the prep time somehow. And Stewart, I think that would be a great example of the fundamental learning application being changed, where we're really applying the knowledge here in such a direction that it's a interprofessional effort to try to improve on quality, improve on value, improve on satisfaction.
Great. And I got a note from Andrew Carr saying that he's actually planning a flipped session within an annual conference as we speak. Unfortunately, Andrew, I don't see that you enabled your audio feature, so I can't unmute you. But if you would like to type in some more information in the chat function or enter the PIN, we'd love to hear what you're doing. And in the meantime, Mila, you had a comment?
Yes, a couple of things come to mind, following on the recent discussion, and in particular, one of the points that Bill was making. So I think the performance improvement component in continuing medical education in the quality improvement world is really well suited for this approach, and we could even think of the PI-CME, the three-stage concept, as already being a flipped classroom in a way. So for those of us who are engaging in such activities, if you think of the assessment in practice, which is that first phase, that could be a flipped concept if you're looking at, you're inviting folks in a closed group to look at their own metrics on a given measure or something like that. And then, you have the same group come to the grand rounds or clinical conference session to then do the problem solving around the measure as a group. And then, sending people again out in terms of a reassessment in practice and doing that as a continuous improvement effort. To me, that sounds like something that has already built those elements in it. The other point I sort of thought of is the critical importance of the assessment that we need to solve in continuing education within such a concept. And by that I mean, the assessment along the way. So not the formative, rather formative, not the summative assessment that would inform this process for the instructor. And in particular, challenging situation is in the continuing educational world, where we don't have students who are all supposedly at the same level of knowledge and skill, but we have this really dichotomous group of learners with their skills all over the place coming together, who have trained in different environments in different times, and they're coming together around a topic or a clinical problem to solve. And so that also brings me to the final point, which is the barrier that I see as the primary barrier to something like this, again, contrasting the other pieces of the continuum in medical education, such as undergraduate and graduate, to continuing education, with this notion that A, we don't have the curriculum set, and B, we don't have a group of learners who are at the same level of knowledge, skill, attitude, whatever we're trying to teach. So with that concept in mind, it seems like this pre-work of the flipped concept would focus maybe more on bringing people to the same point of starting something new in terms of problem solving and interactive learning, rather than bringing necessarily the new knowledge to everyone. That seems to be the focus of these other efforts. And that I'll stop with that. Thank you.
Terrific. And I think Andrew is connected now. We can't wait to hear about your experiences.
Yeah, can you hear that now?
We sure can, thank you.
Okay, good. And I've got Dena Silva in here with me, and she can supplement too, since she and I are both planning this activity together. It's part of one of our annual primary care conferences. It's coming up in May. We were looking for something a little more innovative than just a standard presentation, and kind of develop this concept of the flipped classroom using team-based communication. And it's improving patient safety in team-based communication, or with team-based communication, based on the team steps material. Our faculty, we've got 3 faculty putting this together, are developing cases that the learners will review beforehand. And as part of the conference, as part of the registration process, and as part of the conference itself, we're really emphasizing, please do these cases beforehand. We're going to make them available online and even at the conference in printed format. Since we're just trying this out, we're not sure how it's going to work. One of the interesting things that we're going to do is we want to assess their attitudes and feelings towards this relatively new format of learning, and if they thought it helped them engage more in the learning and help their increase their participation. So at the end of the session, it's going to be a 2-hour session. As soon as they get to the session, everyone breaks apart into teams and begins their assignments immediately. The tables will have the assignments there and led by moderators. The end of the activity, there will be an assessment where they assess themselves on their participation, how they felt their participation was, and they'll assess their team as a whole, not the individual members, but their team as a whole, on whether they felt their team was engaged and if this contributed to their learning at all. So we're still in the design process. We're still trying to figure out what we can measure on this, but we're really excited about it.
That's terrific. We would really be interested in hearing about that, and especially in terms of the attitudinal issues and so forth.
Yeah, and I think that's because probably like most of you, our conferences run from the brand new physicians all the way to the ones who've been retired for 15 years and just looking to keep up a license. So it's going to be interesting, the different responses we get from that.
Definitely. Kudos to you for trying that.
Well, it's a low-risk thing, so we're happy to try it.
That's great. And actually, here at the University of Pittsburgh, for a number of years, we've been working closely with our simulation center, and they actually require pre-course web modules. People are actually required to do those before they come into the Sim Center, which has really saved them a lot of time. They actually used to use a lot of the FaceTime to give the formal presentations, and I'd say they've probably been doing it for 5 or 6 years. They have the hook that people really want to do the simulation, and they have a way of knowing if they've completed the web modules beforehand. So that's been extremely effective and very well received from that experience. I don't know if any of the rest of you who've done that with any of your simulation centers or not. I was also interested in the issue of technology, and there were comments about the fact that maybe the technology isn't as important, but any thoughts starting with the 2 of you at the University of New Mexico in terms of technological applications, and if you're thinking that anything may be more user-friendly. I think we're all concerned about the motivation of people doing things beforehand and trying to find the easiest way and the most adaptable way for people to work this into their daily pre-course life. Bill, do you have any thoughts?
This is Gary. Bill pointed
Gary, yes.
One of the things that the Moffitt paper points out is the possibility of using multiple formats for presenting what would be necessary to master ahead of time, and let the user pick what is most amenable to them. So you might be able to put together, for instance, some text reading, but you might also say, well, you know, I could record a 20-minute or 15-minute podcast. I could make it available that way, or I already know of an existing YouTube, which is very appropriate to provide this activity, or something I found on MedEd Portal, which would be a good introduction to the topic. Another thing to consider if one wanted to put together their own little lecture presentation, which they wanted, because you said, look, gosh, you know, there's bits and pieces of 3 or 4 papers here that would really be important for people to have some understanding of, but I don't want to expect them to read those 60 pages. But I could hit the high points and illustrate them with a case to help them think about what I need them to know before they come, and I could put that together in a little lecture. And the screen capture programs for taking what you already do as a PowerPoint lecture and you just talking to a microphone, and it's just capturing the PowerPoint you have in the screen, and if you're annotating it as you go with screen tools, that's fine. When I teach my classes, I use a program called Snagit that you can buy for $29.99. And it'll just capture what you're saying verbally and whatever you're projecting on your screen visually, and puts it in a file that you make available to your learners to listen and watch, and they can go back through at their own pace and so forth. It's something I often suggest to folks if they do want to do something other than just reading and they want to have their voice and their view represented. Well, you're already good at making that PowerPoint or Prezi presentation. Just screen capture it and make it available for the learners to have as a resource before, during, and after the classroom session.
I'm glad you brought up the subject, Barbara, because I feel very technologically challenged. And I must admit, as a very experienced lecturer, I'm much more comfortable being behind a microphone with maybe a distance from students or learners rather than learning all this new technology that so many of our young physicians already know. So I think this is an impetus for me to improve upon my knowledge as to technology that's available to support something like a flipped classroom here. So I bring that to everyone's attention because there are probably other people who feel the same way as me, and it therefore seems to be much more formidable in terms of the amount of time that's required in preparing an effective learning experience here. I appreciated Andrew's comments a moment ago about his team-based communication as part of the annual course. And I appreciate your point, Barbara, about the simulation lab, the Sim Center. I would dare say that a lot of our courses, we're going to probably move to maybe as much as a third or a half of all the material in the coursework maybe being in a flipped classroom type of setting, because I think it's probably a more effective way of learning here for people who already experienced clinically and really want to be able to problem solve and to take home something here. But getting back to Andrew's comments where he said you'll have very young physicians and then physicians who are 15 years out of practice, that's going to be very, very interesting, because I think some of the learners are going to very quickly absorb all this, whereas some of the maybe more senior people might feel a little bit more on the back stage or in the back of the room, feeling the need to play more of a passive role, or feeling less comfortable in terms of being very engaging in the learning process here.
Yeah, I might just add, I think that's where Mila's suggestion is a very good one. One of the ways you sort of even the playing field is by providing the opportunity for people to engage before the face-to-face activity to the level they need to develop the competency to participate. And that could involve providing a variety of different sorts of resources in preparation from more basic to more advanced. And instead of making each of those a requirement, what's really put out there as the pre-class or pre-CME event preparation is you need to know the answers to these 5 questions, or you need to know these 5 things. And we've got some resources here for you. You can explore them to the depth that you need to in order to be satisfied based on the competencies and backgrounds you already bring as to how much of that information you need to explore in order to answer those 5 questions, so that you can even the playing field so people are more engaged interactively in the teams when they arrive at the face-to-face event, because you've been able to take care of some of those discrepancies in understanding and background through the pre-event assignment.
And I always hate to introduce the C word for credit, but how important does everybody think it is to explore the option for giving credit for the preparatory work? Bill?
I think it's very important. It would only be an hour or 2, but I think having some sort of credit would be very important here. It does require a considerable amount of time often.
And would you feel comfortable in terms of compliance with that? I think we all, a lot of times feel concerned about, the accreditation requirements, and, we talk about is it a live activity? Is it an enduring material? Is this something that we, should be discussing and maybe pressing with the accreditation system, or should we just, do it and, and feel comfortable about it, since it is tied to the, needs assessments and objectives and tied in with the evaluation that we're doing?
Well, in an academic center such as ours and yours at Pittsburgh, faculty can indeed be given credit, although limited, for their lecture preparation, as long as it's an original lecture and it's not a repetitive lecture. And so I think it's very reasonable to do that, but I think the actual quantity in terms of credit, it would be pretty limited to only about 1 or 2 credits.
I think another way one can examine, was there compliance with the credit that was given for pre-event work? I mean, one possibility there is that part of the pre-event work too is a completion of a simple online assessment that not only demonstrates developing the competencies at the level that were expected, but to the extent that the learners had challenges, this becomes a just-in-time teaching tool then for the CME facilitator. We can see what concepts were sufficiently mastered through the pre-class environment and which ones weren't, where we do have discrepancies in the backgrounds of the participants. And so if that pre-event assessment is couched not so much as a compliance test, even though it can be used for that purpose, but as a self-assessment and a planning tool for the event by demonstrating what learners are bringing, I think that the idea that I'm being tested over what I was supposed to do wouldn't come across as sort of a derogatory way.
That raises an interesting point about, using the flipped classroom not only as a way of, conveying information, but also as a pre-activity assessment, so that you can really identify the areas that need to be focused on in the live-to-live interaction. And I was also interested in the comment about, PICME being one example of this. And, I think in terms of formats and so forth, that is very germane to this topic. And as everyone knows, I like to pick on my friends, so I wonder if Nancy Davis might have any comment in that regard. Nancy, are you on the line? Maybe not. So, But I think that's another opportunity for us to think about this and as a model of some of the things that we are already doing. I also wondered, again, we're sort of maybe somewhat new in this field compared to some of the others in other parts of the continuum of education and other domains. How do you think we can help to contribute to the knowledge and literature in this area, particularly with our colleagues in undergraduate medical education and really help to learn from each other? Bill, do you have any thoughts about that, since you're involved in various areas of the continuum?
Well, I wanted to start off first, Barbara, with our medical students, looking at the lecture that I give regularly to just see, first of all, how I felt about it as compared with jumping in with something in continuing education. I think a real advantage to this really relates to the very final tip in Moffat's paper, which has to do with flip does not have to be all or nothing, but it's really a great opportunity, I feel, to evaluate how the effectiveness of what we're actually doing. I think the flipped classroom concept is really important, that the assessment method chosen is appropriate here. And sometimes I wonder if we're really choosing the appropriate method in order to assess the educational value here. And so that's where I feel that CME may come into bearing here, because so many of our learners are experienced physicians who are very practically minded and really want to learn something that they can take home and directly apply. So where the flipped classroom approach may be helpful is really assessing our methodology that's being taken here and how this classroom environment is used to improve upon skills as well as promoting a higher level of understanding. And so by doing so, there might be actually a trickle-down effect as it relates to training maybe the less knowledgeable physicians or students still in the classroom setting.
And Gary, I'm interested, since you're in a non-medical domain, do you see any differences or similarities among faculty in the medical setting versus in your field?
I've been working with a number of the faculty who primarily teach in the first two-year program, the basic science program, who are interested in flipping parts or all of the organ system blocks. The difference that I see in working with those faculty versus those that I've worked with on main campus, I ran our main campus faculty development center for 7 years before coming over to medicine, and still work with a lot of intro-level math and science instructors on our main campus who are flipping their courses through a Department of Education grant that I have. The big difference I see is not the differences in subject matter, it's not the differences in motivation at all. The bigger challenge is the fact that, as is probably true at your institutions, these organ system blocks have as many as 20 different people that show up as instructors during the course of the block. So a single instructor who's interested in flipping their part is challenged by the fact they're bookended by a completely different type of instruction. And that becomes very challenging for the students and really messes up the timeline for their way in which they prepare for class. So that if it isn't really something that's implemented reasonably uniformly, or at least at an appropriately scheduled times through the block, it's really difficult, I think, for it to work for the students, more so than it's something that works well for the faculty. Nonetheless, we're in the process of a curriculum renewal on our first 2 years currently, and several of the block chairs are very interested in exploring this, particularly for some of the shorter blocks that don't have as many faculty involved. And so we're pushing forward with trying to help them accomplish that as a pilot. And I should point out that when we do, out of my Office for Medical Educator Development office, run workshops on how to flip your classroom, you bet we flip those workshops. People go into the learning management system and complete assignments before they come to the workshop. We want them to see that that's the experience that their students would have as well.
That's very interesting, and I wonder if in that regard we don't have more opportunity in CME and building on, Andrew's example where, if we have a larger program, we can offer some, flipped classroom sessions that, could fit very well just as we have breakout sessions that, would be, maybe more logical than in a, multi-topic curricular setting. I wonder if there are any other questions or comments from the audience. I think we've come to the end of an hour. We allowed extra time, but if there are no other questions, I wonder if Gary and Bill, you might have any concluding comments.
Well, one of the tips, Barbara, of the 12 in Moffitt's article had to do with offer training to those involved in delivering a flipped classroom course. And I hope through our SACME Journal Club today that it stimulated some interest in educator readiness as being a very important factor here in the success of the flipped classroom course. And through these principles that we've talked about and provided this example today, that it has instilled some interest here in considering this approach in certain offerings in your continuing medical education opportunities for learners.
Thank you. And we had a question from another one of my good friends, Jane Mihalik, about getting the email addresses of the speakers. We will be glad to provide that. Perhaps Jim can send those out with the email with the evaluation. And I think we would also be very interested in whether you would like to, have some sort of a session or a breakout at the spring meeting or some subsequent meetings of SACME or the medical education meeting about topics like this. It seems like a great opportunity for us to learn from one another and deploy this in different settings and really understand how we can make the best use of time as our clinicians become more and more busy in their practices and more focused on the things that they actually need to apply. So thank you, everyone. We really owe a great debt to our two presenters who have not only done a great job here, but are doing some terrific work in their own institution. So I would like to thank everyone. We really appreciate you taking the time with us today. And if you, please give us your feedback on the evaluations. And if you have any ideas about future topics for the Virtual Journal Club or any suggestions about how we could improve the methodology of the Journal Club or create more engagement, we're very, very open to that and very pleased that you've agreed to participate today. So thank you, everyone.